Imagine it is the late 16th century in Italy, and you have just lost your nose.
Which is obviously a terrible day for anyone.
Right, terrible day. Maybe you lost it to a sword strike in a duel, or, perhaps to a vicious disease like syphilis, which was basically tearing through Europe at the time.
It was everywhere, yeah.
Yeah, so a prominent surgeon comes up and offers to build you a brand new nose, but you refuse the procedure.
Oh, wow. Why would you refuse it?
Well, you refuse it because this terrifying rumor is sweeping across the continent.
Yeah.
People genuinely believed that if a surgeon used donor tissue to reconstruct your face, and that original donor eventually died, the new nose attached to your face would spontaneously rot in sympathy with the corpse.
That is just, biologically speaking, that is entirely impossible.
Right. But that folk myth was so deeply rooted in the cultural psyche and just so viscerally terrifying that it effectively stalled the progress of reconstructive nasal surgery in Europe for, over 200 years.
2 centuries of zero progress because of a ghost story. That's incredible.
It really is. Yeah. And it's stories exactly like that. The bizarre accidents of history, ancient myths, spectacular misunderstandings that are secretly baked into the everyday words your doctor uses right now.
Yeah, people don't usually think about that.
Right, because when we look at a medical chart or listen to a diagnosis, we expect pure, clean science. We expect it to be as precise and, binary as an architectural blueprint.
But the reality is that medical terminology is this wild linguistic time capsule. It absolutely is.
Which brings us to our mission for this deep dive.
Exactly. So today we are exploring a stack of sources that decode the hidden language of the human body, specifically focusing on the upper airway.
The breathing machinery.
Right. We are looking at 3 foundational anatomical roots. So we have naso, rhino, and laryngo.
And just to be clear, for you listening today, the goal here isn't just to memorize some sterile vocabulary list.
No, definitely not. We want to actually map the physical terrain from your nostrils down to your voice box by uncovering the debates and really the history embedded in those exact terms.
So let's start at the very top of that map, which is the nose. And this immediately presents this glaring linguistic puzzle.
It does.
We have 2 completely distinct ancient roots for the exact same physical structure.
Yeah, and to understand that split, you first kind of have to look at how medical words are constructed in general.
Right, lay it on me.
So you usually have a root word fused with a connecting vowel, which is almost always an O. That vowel basically acts as a hinge, allowing you to snap suffixes or other roots onto it smoothly.
So the O in naso or rhino is just the connective tissue holding the word together.
Precisely. It's just a hinge. And for the nose, medicine inherited 2 competing roots. The first is naso.
It sounds pretty familiar.
It does, because this comes straight from Latin, derived from the word nisus. If you look at Roman writers like the Encyclopedist Celsus back in the 1st century CE, he used this as just the everyday conversational word for nose. And because Latin is so baked into the English language, words built on this root-like nasal or paranasal, they don't even sound like specialized medical jargon to us today.
Right, they just sound like everyday English. If someone says nasal spray, you know exactly what they mean.
Exactly. But then we have the second root, which is rhino. And this one originates from Greek, derived from rhis, or rhinos.
Okay, so Latin versus Greek.
Yeah, and this Greek root traces all the way back to the Hippocratic corpus in the 5th and 4th centuries BCE.
Oh, wow. So way back.
Way back. The ancient Greek physicians were using it to document things like severe nosebleeds or nasal polyps. Today, you see it in clinical terms like rhinitis or rhinoplasty.
But here's my pushback on this. If a patient walks into a clinic with a broken nose, why does the medical field need 2 different ancient languages to describe the exact same piece of cartilage?
It's a fair question.
I mean, if they mean the exact same thing, it feels incredibly redundant, like having 2 identical keys for the same door.
And you are touching on a very common trap for medical students right there.
Oh, really?
Yeah. They assume that because there are 2 distinct words, they must point to slightly different physiological structures, but they do not. Anatomically, they mean the exact same thing.
So why keep both?
The survival of both terms is purely a historical turf war. It just depended on which medical subspecialty favored Greek texts versus Latin texts as they evolved over the centuries.
So there isn't actually a hard grammatical rule for when a doctor uses one over the other. It's just vibes.
Well, there is a pedagogical rule taught in medical terminology courses, mostly just to help students organize the vocabulary in their heads.
Okay, what's the rule?
The simplification is that NASO is generally reserved for surface anatomy, structural frameworks, and radiological imaging.
So like the physical architecture.
Exactly. Think of the nasal cavity or the nasal septum. Rhino, on the other hand, is heavily used for surgical interventions and pathological conditions. When things break or when a surgeon needs to fix them.
Okay, but I'm guessing that rule falls apart if you look closely enough.
Oh, completely. Right, because it is just a convention, not a law of physics. I mean, clinicians say nasal congestion, not rhinal congestion.
Right.
But they diagnose allergic rhinitis, not allergic nasitis. And then you have terms that just blatantly contradict the rule altogether.
Give me an example.
So, nasopharynx is a structural term describing the upper part of the throat behind the nose. But if that exact same structure gets inflamed, the standard diagnosis is rhinopharyngitis.
Wait, they switch roots for the exact same body part just because it's inflamed?
Yep. They swap the Latin for the Greek the second it becomes a pathology.
That is wild. It seems like whichever ancient term stuck to the specific disease first just became permanent ink.
That's exactly what happened.
Well, since we established that rhino carries the surgical weight, I think we should dive into its most famous application, which is rhinoplasty.
We definitely should.
Because this procedure has a history that is shockingly brutal. I think most people hear rhinoplasty and immediately picture, a modern, purely cosmetic nose job in Beverly Hills.
Right, which completely ignores thousands of years of reconstructive necessity.
Yeah.
Our sources actually detail this forehead flap technique, which was pioneered by an ancient Indian physician named Sushruta around 600 BCE.
600 BCE. And the driving force behind Sushruta developing this wasn't vanity at all.
Not even a little bit.
Because amputating the nose was a standardized institutional punishment in ancient India for crimes like theft or adultery.
And it was also an incredibly common battlefield injury.
Right, so you had this significant population of people walking around with a highly visible, socially devastating disfigurement.
Exactly. And Sushruta's solution to this was mechanically brilliant. You see, you cannot simply slice a piece of skin off the arm, stick it on the face, and hope it survives.
Right, because it's dead tissue at that point.
Right. The tissue will die because it has no blood supply. So Sushruta would cut a leaf-shaped flap of skin from the patient's forehead, but, and this is the genius part, he would leave a pedicle.
A pedicle, what is that?
It's a small bridge of tissue connecting it between the eyebrows. This kept the local arteries intact, so he would flit that living skin down over the nasal defect and suture it into place.
Oh, I get it. Because the blood is still actively pumping through that little bridge of forehead skin, it keeps the tissue alive while it heals onto the nose.
Exactly. It was an absolute vascular masterclass.
That is incredibly clever for 600 BCE.
It really is. But when we look at Europe, things took a very different, much more harrowing path.
Back to our 16th century Italian surgeon Gaspar Tagliacozzi.
Yes. So he attempted to rebuild noses too, but he didn't use the forehead. He used an arm flap.
And autograft, meaning taking tissue from the patient's own body to avoid rejection. Which sounds fine in theory, but the mechanics of how he kept that tissue alive are horrifying.
Truly harrowing. He had to maintain the blood supply just like Sushruta did. So Tagliacozzi would slice a flap of skin on the patient's bicep, shape it to the nose, and sew it to the face.
While it was still attached to the arm.
Exactly. To keep the blood flowing from the arm to the face while the nasal wound healed, the patient's arm had to be immobilized and strapped tightly against their own head for up to 3 straight weeks.
Strapped to their face for nearly a month.
Yes.
And this is long before modern anesthesia or antiseptics. The infection rates, the sheer physical agony of that forced posture, it's almost unimaginable.
It was grueling. But the crazy part is, what actually destroyed Tagliacozzi's legacy wasn't the pain of the procedure, it was the myth we discussed earlier in the intro.
The sympathy rotting.
Exactly. The public fundamentally misunderstood his autograft technique. Because they couldn't grasp the science, they falsely believed he was taking tissue from other people, like slaves or servants.
Which is where that rumor spawned. The idea that if the servant died, your nose would rot off your face.
Yep. The Catholic Church posthumously condemned him, and the entire field of reconstructive rhinoplasty in Europe basically froze in place.
A 2-century delay in medical advancement because of a ghost story.
That's tragic, really.
And they weren't even calling it rhinoplasty back then, right?
No, no. The term itself was coined much later, in 1818, by a German surgeon named Karl Ferdinand von Graefe.
Okay.
He took our root rhino and combined it with the Greek word plasein, which means to mold or shape.
So to shape the nose.
Exactly. British surgeons stationed in India had actually witnessed Sushruta's ancient forehead flap technique still being practiced centuries later, and they brought that knowledge back to Europe in the 1790s, which finally broke the stagnation.
That concept of molding and shaping is still the center of a massive cultural and medical debate today, though.
Oh, absolutely.
Because when you look at modern rhinoplasty, there is this intense tug-of-war between functional surgery like fixing trauma or opening a blocked airway in cosmetic surgery. And insurance companies fight aggressively over this boundary line.
They really do, because functional rhinoplasty, say repairing a severely deviated septum so a patient can actually pull oxygen into their lungs, that is a covered medical necessity.
Right.
But shaving down a dorsal hump purely for aesthetics, that is not covered.
It makes me think of architectural restoration. Like, if you hire a contractor to go down into your basement and fix a cracked, load-bearing pillar so the house doesn't collapse, that is functional necessity.
A structural fix, yeah.
Right. But if you also ask them to repaint the front porch because you just want it to look nicer from the street, that is purely cosmetic.
Right.
The complication with rhinoplasty is that the surgeon is essentially fixing the foundation and repainting the porch on the exact same piece of anatomy, often during the exact same procedure.
That is an excellent way to conceptualize it. Surgeons frequently have to provide meticulous, objective documentation like airflow studies or radiological scans just to prove the functional breathing obstruction to insurance companies.
Even if they're also doing aesthetic work at the same time.
Exactly. They have to justify the medical necessity because the physical architecture of the nose is inextricably linked to how it functions.
Which honestly provides a perfect transition for us. Because fixing the external architecture of the nose doesn't do you much good if the internal lining of the airway is completely swollen shut.
Very true.
So let's follow the oxygen inside and look at rhinitis. If we break this word down, we have our root rhino and the suffix iitis, which pretty universally denotes inflammation, like arthritis or appendicitis.
Right.
So rhinitis just means the nasal tissue is inflamed, right?
It does, but this is another linguistic trap for us.
How so?
Well, the word rhinitis makes it sound like a single unified diagnosis, but it actually acts as an umbrella term for a family of conditions that are driven by completely different biological mechanisms. Our sources highlight 3 distinct types that all share this exact same root word.
Okay, let's unpack the mechanics of each one. What's the first?
First is allergic rhinitis. This is a hyperactive immune response. So your body breathes in something totally harmless, like dust mites or tree pollen, but your immune system misidentifies it as a dangerous invader.
It overreacts.
Exactly. It floods the nasal tissues with histamines, causing the blood vessels to swell and leak fluid.
That's the classic seasonal allergy response. Runny nose, sneezing.
Spot on. Then you have the second one, viral rhinitis. This is the common cold, predominantly driven by a family of pathogens called rhinoviruses.
Rhinoviruses, literally named after the nose.
Exactly.
But wait, why do they target the nose specifically? Like, why not the lungs or the stomach?
It actually comes down to temperature.
Really?
Yeah. The core of your body operates around 37 degrees Celsius, but your nasal passages are constantly pulling in outside air, so they sit slightly cooler, usually between 33 and 35 degrees.
Oh, that makes sense.
And rhinoviruses have evolved to replicate most efficiently at that exact slightly cooler temperature. They literally thrive in the specific climate of your nasal cavity.
That is fascinating. The virus is basically seeking out the body's natural air conditioning unit.
That's exactly what it's doing.
And what about the third type?
The third is rhinitis medicamentosa, and this one is perhaps the most interesting because it is entirely self-inflicted.
Self-inflicted.
Yeah, it is a severe rebound congestion caused by the overuse of over-the-counter nasal decongestant sprays.
Wait, the medicine designed to cure a stuffy nose actually causes permanent congestion?
It does.
How does that mechanism work?
So those sprays contain powerful vasoconstrictors. When you spray them, they force the tiny blood vessels in your nose to clamp down tightly, which shrinks the tissue and opens the airway.
Okay, and that feels amazing when you have a cold.
It feels like a miracle. But if you use them for more than, say, 3 or 4 consecutive days, your blood vessels become dependent on the chemical to maintain their tone.
Oh, I see. They forget how to regulate themselves.
Exactly. So when you stop using the spray, the vessels experience this massive, violent dilation. They just engorge with blood, swelling the nasal tissue far worse than the original cold ever did.
Wow.
And patients get trapped in a cycle, using more spray just to breathe, which just further damages the vascular tone.
So it's one root word, but three totally unrelated biological mechanisms: immune, viral, and chemical.
Yep.
And I think this perfectly illustrates why otolaryngology, or ENT, ear, nose, and throat medicine, groups these structures together. The airway does not respect the linguistic borders we try to impose on it.
Not at all. The ear, nose, and throat share continuous mucosal linings and interconnected drainage systems. Like, the eustachian tube connects the middle ear directly to the back of the throat, so an infection starting in the nose can easily migrate.
Which means when a patient says, "I have a sore throat," they might be completely misidentifying the source of the actual problem.
Oh, frequently. Sore throat is a lay term.
Oh.
What the patient feels as throat pain might actually be allergic rhinitis generating excess mucus in the nasal cavity, right? And then that mucus drips down the back of the throat, which we call postnasal drip, mechanically irritating the pharynx. So the problem is actually in the nose, but the pain alarm is ringing in the throat.
We are remarkably bad at pinpointing the origin of our own internal discomfort.
We really are.
Which brings us further down the airway to the final anatomical region in our sources, the larynx. For centuries, this organ was a total medical black box, wasn't it?
It was. But let's define the geography first. The larynx is a complex housing of cartilage and muscle sitting right at the top of the trachea, your windpipe. The root is laryngo, derived from the Greek laryngos. And crucially, the larynx specifically houses the vocal cords.
A distinction needs to be made here, though. People often point to their neck and call the whole area the throat.
Right, but medically, the pharynx is the throat, the larynx is the voice box.
The voice box, exactly.
Yes. And the Greek physician Galen actually deduced this back in the 2nd century CE. He recognized that the larynx was the instrument of the human voice, which disproved earlier theories that the voice just sort of echoed out of the chest cavity.
Okay, but for centuries after Galen, clinical understanding basically hit a wall.
A massive wall.
And that was because of the gag reflex, right? The larynx sits tucked behind the base of the tongue, completely out of the direct line of sight.
Exactly.
If a doctor tried to push something back there to get a look at a living patient, the body's defense mechanisms just took over. The patient would violently gag or vomit. So you can really only study the voice box by dissecting cadavers.
Right, that was the physical limitation of human anatomy. Until, incredibly, an outsider found a mechanical hack in 1854.
An outsider?
Yeah, this didn't come from a university hospital. It came from a Spanish singing teacher living in London named Manuel Garcia.
A singing teacher cracked this.
Yes. Garcia wanted to understand the biomechanics of the voice in real time. He wanted to literally watch the vocal cords vibrating while someone was actively singing. So he essentially invents laryngoscopy using sunlight and mirrors.
That sounds like an Indiana Jones puzzle. How did he do it?
He took a small dental mirror attached to a long, angled handle. By positioning it precisely against the soft palate at the back of the mouth, he managed to bypass the gag reflex.
Right.
Then, he used a second, larger mirror held in his hand to catch the sunlight coming through his window, bouncing that beam of light into his mouth, off the dental mirror, and straight down his airway.
Eliminating the pitch-black windpipe.
And it worked. It did. He actually observed his own vocal cords expanding and contracting. He published his findings and essentially founded the medical subspecialty of laryngology.
But our sources mention this triggers a massive historical debate over who truly deserves the credit for the invention, right?
It does. The debate hinges on clinical utility. Garcia's sunlight trick was a brilliant demonstration of physics. But physicians like Johann Cermak and Ludwig Türk saw this and realized, you cannot rely on London weather to diagnose patients in a windowless hospital ward.
That's a very practical point.
Right. So they adapted Garcia's method. They introduced artificial light sources and specialized concave head mirrors, the ones with a hole in the center for the doctor to look through.
Ah, the classic doctor head mirror. So it's the classic tension between the person who proves the concept and the engineers who make it robust enough to use in the real world.
Exactly. But the mechanical evolution didn't stop at mirrors. Far from it. In the early 20th century, an American laryngologist named Chevalier Jackson fundamentally changed the approach.
What did he do?
He developed the rigid metal laryngoscope blade. Instead of just bouncing light around corners with mirrors, this tool was designed to physically slide into the mouth and literally sweep the tongue and the epiglottis out of the way.
Creating a direct, straight line of sight straight down the throat to the vocal cords.
Exactly. And that physical displacement is what makes modern general anesthesia possible today.
Wait, really? How does it link to anesthesia?
Well, when a patient is put under general anesthesia, they cannot breathe on their own. The anesthesiologist must slide a breathing tube past the vocal cords and into the trachea. Without the line of sight provided by Jackson's rigid laryngoscope design, intubation would be essentially impossible to perform safely.
It is incredible to trace the lineage of a life-saving tool in a modern operating room straight back to a singing teacher messing around with a dental mirror.
It really is.
But what happens when the anatomy itself fails? Let's talk about laryngitis.
Again, we have our root laryngo plus myophytis, inflammation. But when the vocal cords become inflamed, it physically disrupts the physics of sound production.
How so?
Well, to produce a clear voice, your vocal cords must come together and vibrate symmetrically.
Like the reeds of a woodwind instrument.
Exactly like that. When they are inflamed, they swell up, they become stiff and heavy, and they can no longer meet cleanly in the middle.
So air just leaks through.
Yep. Air skates through the gaps without vibrating properly, resulting in that raspy, hoarse sound of laryngitis. Sometimes they swell so much they barely vibrate at all, causing a total loss of voice.
And for anyone who uses their voice professionally, I mean singers, teachers, broadcasters like us, this is a mechanical failure you cannot just push through.
I know you can't.
If the tissues cannot physically vibrate symmetrically, the sound simply will not exist.
Which highlights exactly why understanding this anatomical map matters for everyone, not just medical historians. This language dictates how public health is managed on a large scale.
That's a great point. Like during recent respiratory pandemics, tracking rhinorrhea, which is the clinical term for a runny nose.
Yeah.
That became a standardized metric on screening checklists globally.
Exactly. But the stakes get even higher when we look at the larynx.
Significantly higher.
Yeah. Persistent hoarseness, meaning a raspy voice that lasts for more than 2 to 3 months without improving, is a critical red flag.
Because it means something is continuously obstructing the symmetric vibration of those vocal cords.
Yes. This is the primary early warning sign for laryngeal cancer.
And catching laryngeal cancer early, before it spreads to the surrounding lymphatic system, dramatically changes a patient's prognosis, right?
Completely. It is the difference between a highly treatable localized issue and a life-threatening systemic disease. Laryngoscopy remains the gold standard for that early diagnosis.
Wow. When we step back and look at the entire journey today, we see how much human ingenuity is packed into these terms. We explored how naso and rhino point to the exact same nose, but divide the medical dictionary based on an ancient linguistic rivalry.
From Latin to Greek.
Right. And we saw how the surgical legacy of rhino stretches from the brilliant vascular flap techniques of ancient India through the terrifying myths of Renaissance Europe, right up to modern insurance battles over form versus function.
Then we moved internal, seeing how one diagnostic word rhinitis masks entirely different mechanisms, from viruses seeking out the cooler climate of the nose to the vicious cycle of chemical rebound congestion.
And we ended at laryngo, where the simple physics of light and mirrors unlock the voice box, ultimately paving the way for the tools that make modern surgical anesthesia possible.
It's a huge journey.
It is. But going back to where we started, we talked about our expectation of medical precision. We like to think of the body as an engineered machine, and medical terminology reinforces that, doesn't it?
It definitely does. We build these words by snapping modular roots together. Rhino plus ascositis. Laryngo plus ascoscopy.
We treat the language itself like interchangeable puzzle pieces. A nose here, a voice box there.
Which makes the vocabulary incredibly efficient to learn.
It does, but it leaves you with a provocative question to consider. If the very language we use to describe our health is built entirely out of these isolated, compartmentalized pieces, how much does that linguistic structure accidentally bias us? Does snapping these word parts together trick us into viewing our own bodies as just a collection of separate, isolated parts breaking down? The reality, as we've seen from postnasal drip irritating a throat or virus exploiting a temperature gradient, is that the human body is a deeply interconnected, continuous ecosystem.
It's all connected.
It is. So the next time you feel a cold moving from a tickle in your nose down to a scratch in your throat and finally stealing your voice, think about how forcefully your body's reality rebels against the neat, isolated little linguistic boxes we try to force it into.